There are so many morbidities that coexist in patients with asthma, and I think that's one of the biggest things that we need to address. Obesity, gastroesophageal reflux disease, sinus disease, all play significant roles in interactions. But I think one of the most important aspects in terms of understanding the unmet needs are really what accounts for exacerbations. Currently, there are 2 million emergency room visits for asthma every year and 500,000 hospitalizations for asthma every year. What we need to do is focus on those patients who are the most severe and get a better understanding of the underlying mechanism of disease. How can we predict who's going to have those significant morbidities and healthcare interactions, healthcare utilizations, and what can we do in terms of treating them? We need better therapies, and we need to identify biomarkers that will predict responsiveness to those therapies.
Well, the first and most important is history.
Sure.
Because you're going to pick out a lot from how they're responding to their medications. Say you already have a person who's been diagnosed with asthma, let's talk about those. You want to know their control. How controlled have they been? And that requires sometimes asking questions like, how often do you take your rescue medication? Is it more than 2 times a week? How often are you waking up at nighttime? Can you do your physical activity as you've always done? Or are you having problems with that?
So do you have people in your offices trained to be educators for this sort of thing?
We have asthma nurses and asthma educators. I usually do the initial training, and then after I see the patient, I'll refer them to the nurse right outside my office, who will then make sure that the patient understands how he or she is supposed to take the inhaler and how he or she is supposed to contact us if needed in the event of worsening asthma.
So you have to do it every time they come in to go over their inhaler use and make sure they're not getting sloppy with it, because they do get sloppy.
So right now, patients coming into your office with difficult to treat asthma, severe asthma as we've been talking about, what drives the decision to use one of these IL-5 agents? Dupilumab, what is your take on that one?
Well, that's a blocker of IL-4 and 13, and it blocks a receptor subunit. So it's a subunit of the receptor. They both use that receptor, and that has shown to decrease exacerbations as well as increasing FEV1.
All of these new cytokines certainly generated a lot of enthusiasm at the recent American Thoracic Society meeting in San Francisco. Linda, Michael, what did you learn at ATS this year? What did you contribute at ATS this year?
We're at a very exciting time point now in our management of asthma, because we have got new therapies available. We're developing novel biomarkers, and we're gaining a better appreciation of our understanding of the underlying mechanisms.